And by that, I would like to introduce the first speaker, who is Dr. Marco Degidi. He's running a very successful private practice in Bologna, but he's also an adjunct professor at University of Chieti, also an adjunct professor at University of Bologna, and he's a well-known speaker in Italy and outside Italy, and is also very active in research and have a lot of publications. And the title of Dr. Degidi's lecture is Primary Stability Determination, operating surgeons' perception and objective measurements. So welcome, Dr. Degidi.
Dear colleagues, Lars, thank you for the introduction. And so this morning, very shortly and briefly, I want to share with you our study that we did a couple of years ago, and that is the study about the surgeon perception of the primary stability. So we know that immediate loading is a successful procedure. There are a number of publications that are now on the PubMed, is increasing constantly, meaning that this is a very reliable procedure. However, we know that immediate loading relies, in order to be successful, meet at least those two prerequisites. Achieve a good primary stability and avoid micro movement of the implant interface during the healing time. Primary stability is really something that needs to be probably further defined. As you can see from the EO consensus of a few years ago, is commonly indicated like a lack of movement of the implant immediately after replacement. More generally, is a measure of the difficulty of displacing an object or system from equilibrium. However, whenever we talk about an implant that is supposed to be lowered, we always say that, well, I achieve a good primary stability, then I load it. However, good is, of course, a very undefined term. And the mere fact that we have to rely to use a descriptive adjective, like good, further defined, that we are relying on a very impalpable issue that very strongly is influenced by the individual subjectivity, and it is far from any objective and scientific substances. So good primary stability may be different for me or for you or for whatever. We have been looking for many different methods in order to more objectively evaluate primary stability. And you know that several of these have been proposed, like the Pareto test. There are a series of different torque, wrench, or ratchet that are supposed to give you some idea of a kind of threshold of the insertion torque, and many drilling machines give you, again, an idea, like did I insert the implant with a kind of amount of insertion torque that is approximately close to a certain threshold or maybe below, but we have not really an exact figures. There are only few machines that are in the market that are able to give you exactly an idea of the amount of the insertion torque that, for example, that you deliver, and because they display like a kind of graph, and they give you some like precise amount of Newton centimeters. And also, of course, we have the Osstell device that is the only one available for testing our implant with the RFA technique. Nevertheless, I have to tell you that in most countries, And wherever I've been, those machines, they are not so widely diffused. So most people are still relying on the perception. Most surgeons, they place an implant and they assume that the primary stability is more or less good from like percussion test or basically the feeling. You just place an implant and you say, okay, this is a good load, it's entered with a good torque, I think I can load it. So we did a very simple study. We evaluate the difference between the dental surgeon perception and the real values of RFA and insertion torque. You see, in 2007, we observed a group of 152 patients. And on these patients, we place always the same implant. So this is, in this case, was the Xide implant. 517 implants consecutively placed. The implant distribution, you see, is more or less in every anatomic region of the mouth. And of course, we met all the different bone qualities. And basically, all range of lengths and diameter of the implant has been used. Of course, we are talking of these particular implant systems. All the implants were inserted by the same oral surgeon who has considerable experience in implant surgery and immediate loading technique. Now we can divide this simple study in 3 chapters. The first one is guessing. For all the 514 implants, immediately after the insertion, the oral surgeon was asked to indicate the probable RFA values according to his perception of primary stability and, of course, also the probable insertion torque values. The second step was actually to measure this value. So the RFA was measured, of course, with the Osstell Mentor, and the torque was measured with the H unit E that has the possibility to give you the peak torque and a lot of data. Then, of course, the third and last step was grouping. We grouped all the records in 3 groups: low, medium, and high values. This was true for the ISQ and for the torque. So those more or less were the group. Let's see the result. The mean, and I underlined mean, perceived RFA was 72.2. And you see that the mean real RFA was 73.5. Of course, you have to look at the range, and the range was more or less huge. So we got a huge range from 26 to 90 here, and from 35 to 94. And this is why, even if the results seem so close to each other, the difference indeed was statistically significant. As to the perceived insertion torque, that was 39.1, and again, the real mean insertion torque was 39.9. But again, I want to underline the range that was from 5 to 90, from 4 to 71. In this case, the difference was not statistically significant. These are the mean values and distribution. So these are the perceived, and these are the real value. And maybe with this is easier. So what you can see is the torque, the real torque is distributing more or less 1/3, 1/3, 1/3 in the low, medium, and high value. Why the RFAs has a tendency to have higher values and medium. So, but altogether, you see those 2 values are higher than those 2. So the real values, the first result is that, of course, this kind of implant is able to achieve